So we are given a 55-year-old man who presents with a history of watery diarrhea. Now, if you see the CT images, this is CT images given to me. Now, how do I present this? Now, I am given with a contrast enhanced CT image of the abdomen, which is showing a speculated lesion which is present in the center of the mesentery, which is showing a hyperdense foci within, which is nothing but a calcific foci is seen, and this lesion is seen to cause some desmoplastic reaction. We can see some haziness in the mesentery and some tethering of the bowel we can see, suggesting some desmoplastic reaction that has happened. So and there is some hazy fat is seen around. Now, based on all these things, the most likely diagnosis that comes to my mind is a carcinoid tumor. Now, when I think of carcinoid tumor, the next thing that I have to ask is for images that are containing liver, because that's the most common site of the metastasis of the carcinoid tumor. So if in case we see an hyperenhancing lesion in the liver, and then again it is confirming that this is a carcinoid tumor. Now, going on to the next slide. In this slide we can see that again we can see there is a soft tissue density lesion which is present in this mesentery. Also we can see some amount of tethering of the adjacent bowel loops. Okay, so again my diagnosis in my mind now is carcinoid tumor, and I have asked for images that are showing liver, but I am provided with this nuclear scan. So this is nothing but indium 111 per technate scan. Now this per technate scan will show uptake whenever there is a carcinoid tumor, and if you see in this images we can see that there is a lesion in the center of the abdomen, that is the same lesion that what we saw. So this will confirm us the diagnosis of the carcinoid. Now, along with this lesion, we can see in the area of the liver, in the uptake region of the liver, we can see one nodule in the liver, again suggesting that there is a nodule in the liver which is having uptake by this pertechneate scan. So this will suggest us that there is a metastasis to the liver. Now if I am asked for the diagnosis of this case, now I'll brief that I am given a CT contrast image of abdomen, and I am given a nuclear scan of the body after giving technetium the indium 111 per technate scan. Now based on these findings, I can tell that there is a carcinoid tumor in the mesentery with a liver metastasis. So whenever I get a mesenteric mass, the first thing that I have to identify is that whether it is a cystic lesion or whether there is a solid lesion. For example, if I am given an MRI image, the first thing I have to see in T1 whether it is hypointense, whether it is isointense, or whether it is hyperintense, and in T2 again I have to see whether it is hypo, iso, and hyper, and then we have to compare it with contrast enhanced image. If there is enhancement in the lesion, that means that it is having solid component, but if it is not showing any enhancement, that is means it is having cystic component. And if anything, that is T1 hypo, T2 hyper, and not showing enhancement, that means it is cystic. So very easy. First thing is we identify whether it's a cystic or solid lesion. Now once it is a solid lesion, then we have to see what type of margin it has. If it is having a smooth margin, smooth with lobulation, or a smooth margin, then it is usually we have two conditions, two to three conditions that are: one is it can be a GIST, the second thing it can be a neurogenic tumor, the third thing it can be a solitary fibrous tumor. Now a GIST is a heterogeneous tumor which is having few cystic areas within, can have calcification, but it is showing early arterial enhancement. A neurogenic tumor is again a tumor which can contain cystic areas, and it is also showing arterial enhancement. But very classical about neurogenic tumor is it is very bright on T2, which will not be seen in GIST. GIST will have bright cystic areas, but the entire tumor itself will not be bright in GIST. Whereas solitary fibrous tumor is also heterogeneous, but it will have delayed enhancement. It will have delayed enhancement and it will have non-enhancing fibrous component as well. So if I get a well-defined tumor, you think of GIST, you think of a neurogenic tumor, you think of a solitary fibrous tumor. And but if it is having some infiltrating border, or if it is having certain speculated border, now one of the things that we have to think of is carcinoid. And what is classical of carcinoid? It is arterial enhancing, very enhancing in arterial space, and it is usually present in the ileal location. It will cause tethering of the ileal lumen, so that is carcinoid. So it will cause tethering of ileum. It is arterial enhancing, then you think of carcinoid. But if it is containing, again, distorting margins but delayed enhancement, then you think of desmoid tumor or a sclerosing mesenteritis. The sclerosing mesenteritis, the mesenteritis alone will not be having this tethered border and all that, but a sclerosing mesenteritis will have like mass-like lesion with some sclerotic margin. And desmoid tumor is also a fibrous tumor similar to solitary fibrous tumor. Even desmoid can be well defined, but it will have certain desmoplastic reaction which is leading to a distorted margin. So early enhancement, very clearly infiltrating border, early enhancement, carcinoid. If it is delayed enhancement, then you think of desmoid or sclerosing mesenteritis. Now if it is containing fat, which is clear cut of liposarcoma, but when there are multiple lesions, then you think of lymphoma, mesothelioma, metastatic disease are the main DVTs. Now how do you differentiate a metastatic disease? In a metastatic disease, we will have a primary tumor with multiple lesions which are present, with few there might be ascites. Now mesothelioma is also having same thing, but mesothelioma will have thickening of the mesentery along it. So both metastasis and mesothelioma will have ill-defined multiple nodular lesions in the abdomen, but mesothelioma will have mesenteric enhancement, and both will have might have ascites. Lymphoma is very simple. It will be very well defined nodular lesions, bulky lesions present in the abdomen, which is not compressing or which is not obstructing any blood vessels. Classically what we call sandwich sign is what we see in lymphoma. Okay, now we can identify a metastatic disease, lymphoma or mesothelioma. So once we have solid disease, it is easy whether you have to see whether it's a single lesion or multiple lesion. In single lesion, whether it's having smooth margin, whether it's having infiltrating margin, or whether it's a fat containing lesion, very simple, will come with the diagnosis. Similarly, in cystic lesions, we have to see whether it's a unilocular or multilocular. Now with the history of pancreatitis, always we think of a pseudocyst. Now that is excluded. So if there is no history of pancreatitis, there is no features of pancreatitis or chronic pancreatitis, then what we think, we have to think of other things. Now if it is associated with bowel, well defined circular cystic lesion associated with bowel, then you think of a duplication cyst, which is a congenital present, so just a variant which might be present. Now if there is random location, then you think of a mesothelial cyst, and if it is after surgery, we think of lymphocyte. If it is multiloculated and it is going along the path that is present, then you think of lymphangioma. So very simple. Once you get a mesenteric mass, for identify whether it's a cystic or solid. Now let's after understanding the approach, let's see a few of the lesions that are present, how we will go about it. So these are the main differences that we already discussed, how we can differentiate a solid lesions, and these are the examples of how we can differentiate different type of cystic lesions. Just pause and go through. Now, if you see a few cases, so this is a first case. What we can see here, this is a T2 weighted image. We can see there are two hypo T2 hypo intense areas which is appearing hyper on a fat suppressed T2 weighted image. So what it tells us is that this is not a fat containing lesion because bright on fat suppressed image. Also, if you see the surrounding to that, there is an area of mesentery, the where the mesentery is supposed to present. Here we cannot see that clearly because there is fat containing in the rest of the abdomen, so we cannot differentiate. But when we do a fat suppressed T2 image, we can see a bright area here which is very well defined, and it is having well defined margin in the mesentery appearing bright on T2 fat suppressed image, suggesting there is an edema there. So there is an edema, but is it a mass lesion? No. In the contrast enhanced image, there is no mass effect, or it is not a mass lesion to enhance there. So what is it suggesting? It is just suggesting that there is some edema. So edema of the fat in the mesentery is nothing called, it is called fat. Edema of fat is nothing but paniculitis seen in mesenteric fat, so it is nothing but mesenteric paniculitis is what is the diagnosis. It is an inflammatory condition, so we have this enhancing lymph nodes. So that's the only thing that we see. So this is a T1 without contrast, the T2 with contrast. We are not seeing any enhancement other than the lymph node. So that's how we approach a lesion in case of the mesentery. This is one more case in which this is a T2 weighted image. This is a contrast enhanced. This is a T1 weighted image without contrast. This is T1 pre-contrast. This is T1 post-contrast in arterial phase. This is a delayed phase. So we are having an image here, which is we are given a T2 weighted image in which it is appearing very dark, okay, very dark on T2. That means that this is one of the lesions which are appearing dark, and it is showing enhancement in arterial and delayed phase. That means it's a solid tumor. Now it is a solid lesion, or it's a solid lesion which is hypo on T2. That means that it is a highly fibrous containing tumor. One more thing what tells it's a fibrous containing is it is having bright, it is appearing bright on delayed contrast image as well. So that is telling it's a fibrous containing lesion, but and it is having this the speculated margin, and it is having heterogeneous enhancement, and it is a solid lesion. So we saw mesenteric paniculitis then. Now this is nothing but this is sclerosing mesenteritis. The mesentery is containing, is inflamed, and there has been a fibrous tissue has formed there, and now this is nothing but a sclerosing mesenteritis. Okay, ill-defined margin is what is making us think in terms of sclerosing mesenteritis, because very few conditions were there with this kind of ill-defined margin. This is not a carcinoid because carcinoid will not have so much of fibrous tissue. So ill-defined margin with fibrous tissue, we think of the sclerosing mesenteritis. So that's why this is a case of sclerosing mesenteritis. Now this is one more case. It's a variant of sclerosing mesenteritis. So this is a case in which there is acute inflammation and there is fibrotic forms of sclerosing mesenteritis. So we can see again a T2 weighted image. We can see an hypointense lesion which is showing enhancement, which is showing an enhancement in a delayed images. When we see that, it is showing enhancement. Now this is a fat suppressed T2 weighted image. In this fat suppressed T2 weighted image also, it is having some areas of hypointensity, some areas of hyperintensity, suggesting that there is little bit of edema, there is little bit of fibrous tissue. So this is again an ill-defined lesion which is showing some amount of inflammation, some amount of fibrous tissue. This is again a classical case of sclerosing mesenteritis. In this case, what we are seeing is this: in this T2 weighted image, there is one hypointense nodular lesion. See, very bulky lesions. If you see in T2 fat saturated images, they are appearing brighter. Okay, here it is appearing hypo compared to the fat, whereas in this image, in the second image, B image, we can see that they are bright compared to the rest of the image because of the fat suppression that we are seeing. And when we give contrast, we can see a very good enhancement, a diffuse smooth enhancement. Now this kind of appearance, smooth enhancement, bulky lesions, and it is not causing any compression on the blood vessels. So this is a classical case of a lymphoma. This is our lymphoma present, classically what we call the sandwich sign. Now in this image what we are seeing is, here there is a T1 weighted image, and in this T1 weighted image there is an isointense lesion. When we go to this arterial enhancement, it is showing areas of avid bright arterial enhancement. And if you see this the third image is nothing but uh, a T2 weighted image itself, because we can see here there is a bright CSF. So we had the T1 image which is having ISO, which is showing avid arterial enhancement. If you see T2 weighted image, again there is a slightly hypo intense lesion, but what is clinching here is this dense calcification present here and slightly speculated margins. So this not a classical case though, but then this arterial enhancement tells us that this is something which is very enhancing lesion, arterial enhancing lesion. Presence of calcification clinches the diagnosis of carcinoid tumor. We saw this feature. If there is ill-defined margin, very enhancing tumor, then it's usually a carcinoid tumor. Now, this is one more case of carcinoid tumor in which there is a large carcinoid tumor, in which in the T2 it is appearing slightly low signal in fat saturated T2 images, whereas in T1 post contrast image what we are seeing is enhancement of this mesenteric mass. Also, if you see this, there is some edema in this the bowel loops. Usually this happens because of the ischemia caused by these the carcinoid tumors. Now this, in this image, is again a case of carcinoid tumor. What we can see is there is an arterial enhancing lesion here, which is showing uptake in case of the iodine, sorry, indium 111 per technate scan is showing uptake there. And if you see this arterial enhancing lesions in the liver, that suggests that there is a liver metastasis. So that is where the carcinoid usually metastasize. Now in this image what we can see here, there is a large well-defined lesion, and this is a T2 weighted image, whereas this is a T1 weighted image with the arterial phase of enhancement, whereas this is a slightly delayed enhancement. So if you see in T2 it is appearing hypo with heterogeneous areas of hyperintensity, whereas here in this early arterial phase it is not showing so much of enhancement, or minimal enhancement is there. But if you see in the delayed, the enhancement has increased, suggesting that it is more of a fibrous tumor, and it is having, see how the margins are here, it is almost well defined margin. Desmoid tumors can have well defined margin, but if there is any desmoplastic reaction, then only it can have ill defined margin. But large tumors with fibrous component are usually a desmoid, mesenteric desmoid tumor. Now this is a case of very heterogeneous lesion, in which if there in the T2 weighted image we can see multiple hyperintense cystic areas in it. So as I told before, if there is a lesion which is having multiple cystic areas, heterogeneous lesion with cystic areas, not hyper on T2 diffusely, then it is GIST. Now if you see the enhancement pattern as well, this is a T1 weighted images, whereas this is an arterial phase of enhancement. Post contrast image, the post contrast shows diffuse patchy areas of enhancement compared to pre contrast, and the T2 weighted image is showing multiple cystic areas with heterogeneous appearance. This is a classical of a GIST tumor. Now this image is what we can see, this is actually not a classical image. In this is a case of liposarcoma. Ideally any case of liposarcoma will have fat within it, but this is a case of liposarcoma in which T2 there is demonstrates some heterogeneous areas of hyperintensity and hypointensity, and then this is the T2 with fat saturated image, does not show any fat content, but if you see the enhancement pattern later, it is showing areas of enhancing soft tissue within it. So this is a case of sarcoma, but it's not, it is a dedifferentiated liposarcoma was the diagnosis, but this is not how it usually presents. but this bulky lesions, large lesions in the abdomen, presenting coming from the retroperitoneum, usually we have to think of sarcomas. Large lesions from the retroperitoneum, sarcoma is one of the diagnoses in mind. Now in this image what we can see here is there are multiple lesions in the mesentery which is appearing iso or hypo on T2 weighted images, but if you see on T1 weighted images, they're again appearing almost low signal intensity, but once we give contrast they are showing enhancement. So multiple lesions, irregular multiple nodular lesions, but you see this, the surface of the abdominal cavity, there is a thick enhancing membrane here, that is nothing but mesenteric thickening and enhancement, a classical case of mesothelioma. If there was no mesenteric thickness or enhancement, then you can't think of mesothelioma. We might think of even metastasis as well. Then you have to search for the primary tumor. Also, this presence of this ascites is very commonly seen in these kind of mesotheliomas. Now in this image what we are seeing is on T2 weighted images, very bright, see very bright lesion, looks almost like an entirely cystic lesion, but on T1 weighted it is appearing hypo. This appearance is more like a cystic lesion. Any cystic looking tumors with the enhancement, it can be a neurogenic tumor, it can be a myxoid the sarcomas, myxosarcomas. So these are the tumors which are appearing like this, but in context of abdomen, paravertebral appearance, with cystic looking lesions which are showing enhancement with few central non-enhancing cystic areas, and T2 T1 hyperintense areas which can be blood or protein. So this is a case of a schwannoma. Schwannomas, the classical phase, it's a neurogenic tumor, so it will be bright on T2, hypo on T1, that is there here, and it will usually contain cystic spaces can be there, and really it can have some amount of hemorrhage. So that's what we are seeing in this image. Now this is a case of actually a case of solitary fibrous tumor. Now in this what we are seeing mainly here is that in the T2 weighted image, this is a T2 weighted image, it's a lobulated mass with hyperintense and hypointense signal around. So this is a T2 weighted image. So when I come to an arterial enhancement, it is showing areas of enhancement, but center it is not showing areas of an hypointense area, suggesting very fibrous tumor. Now, if you see in the delayed images, again the persistent hyperenhancement is present. That means that fibrous tissue will retain the contrast, and that's what we see here. So this is a case of solitary fibrous tumor. Okay. Now, so till now, whatever we saw are were all solid tumors. Now, if in this image, what we can see here is a T1 weighted image, T2 weighted image. Here there is a post contrast image, and here there is an MRCP. T1 weighted image, it is the lesion is appearing very dark. T2 weighted image, it is appearing very bright, a cystic looking tumor. But how do I confirm it? Do a contrast enhancement, no enhancement again. So it confirms that it is a cystic tumor. Now when I did an MRCP, there is a small duct which is almost connecting it. There is nothing but a pancreatic duct. So whenever there is a connection with a pancreatic duct, we think of a case of history of pancreatitis, and it can be a pancreatic pseudocyst. So this was nothing but a pancreatic pseudocyst. Now this is case again. We can see here the T2 weighted image is appearing bright, and this is a T1 weighted image is hypo, whereas post contrast study not showing any enhancement. Now this was a case of lymphangioma, but only thing is here we just have to know that there can be cystic lesions, and we need to know what are the differential diagnosis for cystic lesions. It can be lymphangioma, which usually is multiloculated, but if it is a single lesion, then it can be a duplication cyst, it can be pancreatic pseudocyst, or it can be a mesenteric cyst. So these are the different cystic lesions which we can see in the abdomen. So this is how we approach any mesenteric lesions. See whether it is a cystic lesion, see whether it's a solid lesion. If cystic, see whether it's a single cystic, or it is multiple cystic, or it is multiloculated cystic. Now again, if it is a solid tumor, again we see whether it is a well defined, whether it is an ill defined, whether it is a fat containing lesion. So this is how we go about the lesions in the mesentery.